Good evening, folks. Thank you very much for being here tonight. We really appreciate you supporting what we're doing, and we're glad that you came here for this part of the tonight's presentation. We are extremely lucky to have an expert in the field of mental health here with us today, and it'll be my pleasure to introduce her and let her tell you a little bit more about herself. My name is Jerry Sipp. I'm the Artistic Director of the Justice Theater Project. On behalf of everyone who works here, we are just welcome you back. We have been mostly doing our shows online and making films for the last year and a half, and we're so happy and fortunate to be able to be doing live theater again. So thank you for being here for our very first production live since February of 2020. Wow. It's hard to fathom that. So, let me give a brief introduction to our expert speaker here tonight. We're so fortunate to have Dr. Tara Bates-Duford here with us. She is the CEO and founder of Family Matters Counseling Group in Raleigh and Orlando, Florida. She's engaged in extensive work and research on familial relationships, family trauma, and dysfunctions. She's known for her work with traumatic experiences and symptom re-emergence. With nearly 20 years in the field of behavioral sciences, she has been instrumental in her work with stabilizing families, helping individuals and families navigate the challenges of mental illness, as well as aiding victims of abuse and trauma to reprocess the memory of the trauma in a manner that no longer paralyzes or interferes with their daily function. She is an accomplished author of children's books, and they cover such topics as conduct disorder, ADHD, parenting and child with special needs, and also trauma. Dr. Bates-Duford has a PhD in forensic psychology, is a licensed marriage and family therapist, a certified relationship expert, and a certified master forensic social worker. Wow. I need to slide farther over this way because I'm not worthy. She has conducted research, therapy, and training on sexual trauma as well. Dr. Bates-Duford has appeared on 2020, the John Benet Ramsey story, and Investigation Discovery, Evil Lives Here. If you could please help me welcome Tara Bates-Duford. So I'm going to do a very poor job in trying to interview the doctor here because I am certainly not a mental health professional, so I may ask some clunky questions. However, we'd like for you to be formulating some questions as time goes along. And if you have something you'd like to ask, please raise your hand and we'd be happy to give you a question to about it.
Okay, disclaimer. Although I've been in the field for 20 years, I'm only 32.
Well, in those short 32 years, I'd love if you could just tell us a little bit about yourself and tell us, what on your journey brought you to this, your interest in this field and helping so many people.
Well, I developed an interest because of my own life growing up. Familial dysfunction, which really means is that you come from a dysfunctional family. And with a history of sexual abuse and incest for 15 years, I wanted to understand how this occurred in families, and I also wanted to understand why families didn't communicate about these issues and why it was so hard in different cultures to communicate when we needed help.
That's fascinating. This show that you're about to see tonight is in many ways about mental illness and depression, and even it's one of the themes is also suicide. So it doesn't sound like a very cheery show, does it? But I promise you that when you leave tonight, while you may have had a tear or two, or may have had some heartache during tonight's journey in the show, you'll also, I think, find a lot of brilliant things along the way. And one of the reasons that we chose this production in particular is that, and again, please, if I say something clunky, please correct me, but I know there's a huge difference between some clinical depression and what we all are probably feeling right now, having lived through this horrible pandemic and being isolated from one another for so long and that kind of thing. Some of us are grieving the loss of loved ones during this time. There's others that are recovering from a severe illness or have family members that are doing so. And again, all of us have been isolated. I was just wondering what your thoughts were about what we're all going through collectively, and you know, perhaps what we might, maybe some tools that you've used over the years that might help us all to improve our mental health.
I would have to say that we all have to understand that because of the pandemic and because of social isolation, which we didn't realize was so important to us, that we're struggling with significant sadness, which is different than clinical depression. To say that we're all clinically depressed would really kind of minimize what some people are going through. There are people that find it hard to function. There are people that are in the midst of attempting suicide, and we've had completed suicides. So there's a big difference between significant sadness and clinical depression. And I believe in order to honor those that are suffering in a way that they don't see an outlet for tomorrow, we have to recognize and make the distinction between the two.
It seems like to me that we often, you know, have simplistic ideas of what depression really is. We go, well, yeah, well, I'm depressed, or yeah, you're depressed, whatever. Get over it, you know, buck up, and everything will be fine. And we know that that's not the case, but I do think that's a prevalent thought. How do we get past that to really recognizing what clinical depression is and how we might be able to help those that we know and love that might have it?
Clinical depression usually is an interference in daily functioning. And what that means is our eating, sleeping habits change, our cognition's ability to think and process information is delayed or interrupted. And it could be self-isolating too, because when you're depressed, it seems more of a chore to be around other people. And people that are significantly depressed often don't see a reason to extend their lives to the following day. So even thinking about how should I end this is a form of clinical depression. The symptoms must last at least 6 months, and they must be debilitating and destabilizing, meaning you cannot go on conducting your life in the manner in which you were doing. We have to be careful also, because when we think about clinical depression, we often are really excited when the person seems to be coming out of it. That's the most dangerous time for them, because those that are profoundly depressed, usually they don't have the strength, cognition, and wherewithal to plan a suicide attempt. But those that are coming out of it, their thoughts are becoming more formed, and they can start to actually devise a plan. So when you see someone that is starting to come out of it, it is most important at that time to get them help. Those that are profound, it's like they're just there, right? They don't have that strength and that cognition to put anything together. Case in point, you ask them a question and they seem lost. They can't really answer a question that seems pretty straightforward, but when they're coming out of it, they become more elaborate and sophisticated. That's an indicator that they can think expansively, and they may need more help then than they would at any other time.
Is it? It's my understanding too that you know, folks who go on medication get some help, start to feel a little bit better, and then feel like they don't need the medication anymore. Is that a common occurrence? And
It is because they think that they've gotten better on their own. And sometimes when you get better, it's hard to see the benefits of the medication. The best medication, you really don't feel too different. You feel like yourself at your core. That's called your baseline. However, if you're feeling something completely opposite of you at your baseline, the medication is either too high or too low. So when they're feeling better, oh, I'm cured. And they stop taking the medication. However, we tend to decompensate when we don't take the medication, and we can slide into mania, where they become overly creative. I knew a woman who stayed up all night painting her apartment black because she wanted to create a sky setting with stars. And she was very creative, didn't sleep at all, was mumbling, and when she would write something, the more manic she became, the closer her words became. It was like one running word all through the pages. And on the outside looking in, I could see that over the time span she was becoming more manic, but to her, she was becoming more creative. The medication that she was taking was helping her, but when she stopped, she did what's called a decompensation. All the benefits of the medication had worn off, and the symptoms that were being held down by the medication were allowed to come and explode.
Sure.
In addition to the medication that's treatment, what are some other treatments that might go along in addition to medication?
I believe that psychotherapy, in addition to medication, is important because at the end of the day, you want to learn how to live with it. There are some disorders where you can get off the medication, but you can't know that until you stabilize. So even a psychiatrist, some people think that when you go to a psychiatrist, that's all you need to do. Psychiatrists are psychopharmacologists. They write prescriptions. So if you notice, your appointment with a psychiatrist is maybe 15 minutes, and they keep stopping you and cutting you off. They really don't hear you. All they want to know is that there's symptom abatement. And there are people that complain that, oh, I only have 15 minutes. That's what they're there for. They just write the scripts. Therapists, psychologists, what I typically do is when I know you're on medication, I'm watching to see how you respond to the medication. I have you lean over, bend over, touch the ground, and get up because I want to see if you're having side effects that you haven't picked up on. I like to look at you when you speak just in case there's drool coming out of your mouth that you may be unaware of. You know, like, oh my God, I feel like I have a hole in my lip. And if you feel that too much, you assume it's you. Or you miss the ground and fall. You assume that's you, and that's vertigo. So there's a lot of reasons why psychotherapy is really important in combination with medicinal treatment.
Can you also tell us, just briefly, describe for those of you who are not familiar with it, including myself, what is does a forensic social worker do? That's good.
I like to get to the core. Forensics, it means partially we're nosy. We want to know really what came first, the chicken or the egg. Some mental illnesses are triggered by alcohol and substance abuse. Some substance and alcohol abuse can mimic a mental illness where the person is actually receiving medication for an illness that would not exist had it not been for the drugs or alcohol. And then there are some that they have the symptoms and they're drinking just to self-medicate to try and deal with what they're going through. So it's really in trying to understand what happened. It is developing an understanding. And as a forensic person, I studied like trauma and sexual abuse because I wanted to understand how what happened to me happened to me. Now, some people may run from that idea, but the goal was to figure out how can I help you if I can't understand me. So I needed to know why these things happen. So maybe in my understanding of me, it would give me a deeper, more profound understanding and appreciation for you.
If we were to begin to suspect that someone in our lives was dealing with possibility of clinical depression, what would be the proper steps to go about to try to give them the help that they need? Obviously, we can't force them to, but how would we go about getting help in that?
I think the best way is to let them know that you're concerned. Don't do anything behind their back because we don't know what the diagnosis is. It could be depression or it could be something like bipolar, which some people like to say bipolar depression. Bipolar depression doesn't really exist. after a while, when you have someone who says, I'm bipolar depression, they drop the bipolar and keep the depression. Bipolar meaning anxiety and mania with depression, two poles. So if you hold down depression, wouldn't mania run rampant? The goal is to find out and talk to them, say you're concerned, because we don't know whether it's clinical depression. It could be other illnesses that are mimicking one thing or another thing. So it is, hey, I'm concerned about you. And be specific. Lately, you seem like you lost interest in friends. You seem like you want to be alone more. I see that you're sleeping more. Because they're looking for concretes, whereas you see it, they don't necessarily see it. So you want to be specific and say, hey, I noticed some changes. What's going on? I'm concerned. You don't want to call in the cavalry, because then they lose trust and then they start to become secretive about the things that they do. They'll start to think that maybe you're not as genuine as you say you are. Maybe you have something against me. Maybe you're manipulating me. If I'm concerned about you, I want to be clear about that. And I want to say why I'm concerned about you. So at least they know out of everything going on in their lives, you are the one constant. You are transparent and authentic with them. They don't need to guess your intentions. You've told them what your intentions and your concerns are.
Yes.
Back to the pandemic, this year and a half of being isolated, as you mentioned, there's a great increase in sadness. I mean, there's just a lot of real sadness and probably an increase in clinical depression. And I think I read that there's a significant enough increase in suicide to make it a concern. And are these things primarily because of the isolation with the pandemic? Are they things that will go away once we get to a more open environment? Is it a cause? Do you see that as a cause for concern that all of this was maybe looking underneath all the
It
time?
can be. It's hard to tell because sometimes the pandemic has already triggered or woken up something that was dormant. Most people that are really, really social, they like having the company of being with others and not necessarily being with themselves and their thoughts. So it's hard to pinpoint that. But what this pandemic did was bring to the surface all the things that may have been dormant. We thought that social interacting wasn't important, but we realized we were wrong. Because social interactions are the one thing that separates us really from animals. That's why you see an uptick in violence too, because we revert to aggressive actions. We begin to really not be ourselves. So now that we're seeing how social interaction kind of benefits us, because we learn by a system called modeling, even if you don't realize it's happening. When you see someone doing something and it appears to be more effective than what you're doing, what we do is edit ourselves to do what they did. Even if you put two babies in a room and one is walking or one is pulling themselves up, the other baby will do the same thing. Modeling. And without the modeling, we're left with these thoughts that are becoming more exacerbated. Because there are things we want to communicate, things we want to unload. But who do you unload them to? So this is why this time is so difficult. Even people that are introverts like the idea of saying, well, if I want to hang out with her or him, I will. But you don't have a choice now. That's really the problem. If you want to spend time with others, you could at any time, any second, you could just jump up and do that. The pandemic has placed an interference in that, so now we don't have a choice. And with the loss of choice comes a loss of freedom. So we're all kind of struggling in this area with the loss of freedoms. Not necessarily social distancing, but the loss of freedom and the loss of choice.
Go ahead, answer.
Going back to medication, the medication worst shields and best treats, but doesn't cure. What is the cure?
Could you repeat that, please?
Yeah, if we're going back to medication, depression, so if the medication is like shielding or treating best of curing, where is the cure? What is the cure?
There are certain diagnoses that there is no cure. There just aren't. I mean, we can go, say for instance, if you have a mental illness, you can go into full sustained remission like a cancer, but it will still be there. Schizophrenia, there is no cure. And schizophrenia does not respond to spiritual counseling. It actually heightens the mania, because most of the issues involving schizophrenia is associated with religiosity, thinking I'm God, I'm a prophet, I'm this, I'm that. So it gets triggered, right? And we know with that diagnosis, there's no cure. But you can go into a full sustained remission or a partial sustained remission where you have some symptoms, but not all. Bipolar disorder, same thing. You can come out of depression, you can come out of anxiety, but the hard ones, and I call the hard ones schizophrenia, schizoaffective, bipolar disorder, significant mood disorders, those are the hard ones. The other ones, yeah, you can kind of ride it out. And there are certain diagnoses that are situational, even clinical depression. Example, I had a family that I was working with that was in a shelter. And there were issues of domestic violence, there was issues of substance abuse, and they lived in a shelter. So I would expect her to be clinically depressed because of her situation, the loss of her home, her liberty, and having to, come in at 5 o'clock every evening to be counted in order to have a bed, and knowing she couldn't provide for her children. That's to be expected. When she was able to secure housing, I saw her diagnosis end. Maybe not right away, but maybe like a month or two afterwards, she was fine. And that was called a situational depression. Had it not been for your situation, you would not be struggling with these mental health concerns. So there's a lot of issues with regards to mental health where there's no treatment. Psychopaths can't be treated. Narcissists, touch and go, because first they have to buy into the fact that they have narcissistic personality issues. And sociopaths cannot be cured.
So, coming to the actual production, Millen says here in later that Millen's message in every brilliant thing is that no matter how dark life may be, it may not be brilliant, but it will get better. Based on what you said 5 minutes ago about the closest person being the best that they can do is be honest, isn't that a dishonesty? Is that he's betraying?
I can't really hear it. Sorry.
So I'll try to address that, and then let the doctor comment on it. So what the gentleman is saying is that one of the lines in the play is really the character says something to the effect, pardon me if I paraphrase, that those of you who might be entertaining suicidal thoughts, I have one simple thing to say to you, that's don't do it. So things can get better. They don't always get brilliant, but they can get better. I think he's saying they get better is probably the exact quote, but I believe that the intention of the author and that in that person's experience, and I believe the author who has personal experience with this, was saying, again, I think someone with a suicidal thought is probably different from someone who's being diagnosed with psychoses or other schizophrenia. Or other.
It's different. There are people, some of us have thoughts of, maybe I shouldn't be here. Is that necessarily suicidal? No. The difference between a real issue, and they're all pretty real, I should say, but we analyze if you have suicidal thoughts or you have a plan. That's the difference. Because we all have thoughts like, this just isn't working for me. I don't even know why I'm here. But then there are other people that start to say goodbye to people in different ways. What they'll do is start to give away clothes and money. And then they'll start to say things like a closeout conversation, like, you know what, I want you to know that although I'm not feeling like myself, you've always been there for me. Or they leave definite phrases like, you know what happens? Know that I love you. So that's different from suicidal thoughts. I'm assuming when the author says things can get better in a suicidal plan. For individuals with a suicidal plan, it means you have, and we'll plan it out. Okay, I'm gonna drop the kids off at school. And unfortunately, this has happened too. I'm gonna drop the kids off at school. I'm gonna come back. I'm gonna call mom and dad. I'm going to take all the money out of my account. I'm going to let them know where to find it. And then I'm going to take that gun and kill myself by 12 noon. Those are pretty different. And I think sometimes because we use them interchangeably and synonymously, they can be confusing. Because suicidal thoughts are just that, suicidal thoughts. But when there's a plan involved, then we've kind of turned the corner on this. I'll say something personal. I remember when I was thinking at 15, like, why am I here? It started that way. I started asking my mom, why are we here? Why am I here? Things aren't getting better in this house because there was a lot of sexual violence, there was a lot of physical violence. And I said, I have no idea why I'm here. And she would say, well, there's a purpose. And then I started thinking like, okay, do I really want to be here next week? Do I really want to do that? And then it turned into, you know what, by Friday, I'm going to kill myself. So it turned into a plan. And it wasn't that I stopped me. It was someone else stopped me. Because it was like I hung myself in the closet. And it was almost like standing on the outside, watching yourself hanging from the closet. Because I had created a plan. There's usually a cry for help when someone starts to say things like, I don't know why I'm here. That's the moment to intervene. But when everyone's kind of coddling and saying, things will get better, it didn't. I started coming up with a plan of action, and I noticed that I would kind of hold on to the pole to see if it could sustain my body weight, right? And I did this a few times. And then it was like, okay, this sweater is going to tear. So I started planning out until I started to feel better. Then I had the wherewithal to, okay, when mom goes to the bank and the house is empty, I'm going to kill myself. Because not only did I have the physical strength, but I had the mental capacity to plan it out and test different items to see how they would sustain my weight. So again, it's not the thought. It is really the intent and the plan behind it. So that's where I'm assuming that author has, it'll get better because there are thoughts, but then there are plans.
So, sure. Something personal. What happened that the plan wasn't carried out?
What happened was my mother came home. Now, I had lost consciousness. I don't remember that part. I had lost consciousness, and from what I understand, was foaming at the mouth. So what happened was when she came home, all I remember was being in an ambulance. I don't really have a recollection because when you lose air and your oxygen is impeded, you lose consciousness. So what I do remember after that was when I did go to therapy, I had to be contracted. And that contract was I would not try to take my life unless I called my therapist first, called 911. And it had long-standing issues because for a while, what we don't realize is it really destroyed my throat. I know, that seems weird, right? It really did. When you do this, it destroys your throat. And even now, if I try to raise my voice a certain amount, it just cuts out completely. Totally cuts out. And it was because of what I did then that some of the issues that I struggle with now are just the remnants of choices and feelings I was experiencing in the past.
So, thank you for sharing that intensely personal stuff. It's very, very,
I just want to know what changed.
I went to therapy, and I also took medication for depressive disorder because I realized that even with psychotherapy, it was great being in her office and being heard, but when I was alone with my thoughts, that's when the problems emerged. So I really needed to slow down the thoughts. It's like having a desk fan, right? And you create a paper plane and you try to throw it to the other side and it just bounces back off. It was fine. I had to slow down the blades in order to hear and receive what was being said to me, and that's where the medication came involved. So I used a combination of both. And also, with myself, trying to understand myself, I started journaling my feelings and trying to identify a trend in my own behavior. Using a blank calendar and putting a blue dot for when I was feeling depressed, I started seeing that there was a theme. Certain times of the year, certain familial conflicts would prompt me to really have these suicidal thoughts. You have a question back there?
I think I saw your hand up first, and then we'll
Yeah.
talk to Mr.
I was wondering if, with the therapy, if someone intervened in the cycle of violence in your family?
Did someone intervene?
Did somebody intervene?
No. No one intervened because as a part of different cultural beliefs, it wasn't okay to talk about your feelings. That just wasn't an option. And the thing about it is, even though that there were discussions that we wanted to have, no one said it because it was almost like you needed permission from the matriarch or patriarch of the family in order to do that. And there's a distrust of mental illness and mental health workers, including myself, which is really prominent even today. So no, I didn't begin to understand the impact of mental health and how treatment really provided an option for a lot of people until I became a provider myself.
Thank you.
I just have a clarification. You said earlier that many conditions are not curable. Specifically for clinical depression, is that curable or no?
It depends. If it's there's moderate, there's mild, so and there's chronic. When we hear about different disorders, what you don't hear about is that they have many subcategories. Many of them do. Only like someone who works in that area would know. Even bipolar, there's type 1 and 2. There's different things. So when it's chronic, usually you'll have some form of clinical depression throughout your life. If it's moderate, you can go into like a full or partial remission. If it's mild, then it could be something called dysthymia. It could be situational. Again, there's many variances. But in order to understand that, again, there are different types and severities of a lot of illnesses that often go unsaid because we use like a blanket term to refer to clinical depression, bipolar, schizophrenia. There's paranoid, there's disorganized, there's different types. There's flat affect. It would be too much to try to explain, but it would depend upon the severity, how long you've had it, and whether you remain in a situation that continues to produce the result, but you're expecting a different outcome. Say, for instance, if I'm living in a violent, chaotic home, and I'm being treated for clinical depression, I can get to moderate. I can, reduce some of the symptoms, but not all, because I haven't changed anything else.
Let's talk a little bit about families and young people and your work with them. The character in Every Brilliant Thing begins experiencing his first experience of depression. I think he's 7 years old or something like that, and he begins to have his own feelings similar to that as he gets older, that he's dealing with his family. So can you just talk to us a little bit about your work, specifically your work with families, and also how that affected your work as an author of children's books to help young folks?
Well, a lot of times we see the symptoms in children that are like 4 or 5, because that's really when we pick up spectrum disorders too. If you see a child that may have conduct disorder or they have other issues, really, those are placeholders for something significant once they turn 18. I'll give you another example. When I was in Florida, because I'm in there part-time, I was in Florida, and there was a child that really kind of made me uncomfortable. He was adorable, but he was really made me uncomfortable. And he really kind of hated human touch. He hated for people to hold his hand, and at first, we kind of assumed a spectrum, right? He didn't like that, but this one woman, he would allow her as at 4. One woman, he would allow her to put him on her knee. She'd hug him, but he'd be like this look like, when is this going to be over? And she would rock him back and forth. And I asked her if she had a child on the spectrum, and she became angry. She did, but I don't know if she thought I would know, but she was overly affectionate to a child that didn't like to be touched. And he was ruled by his former therapist as a conduct disorder. I thought he had psychopathic symptoms, which you cannot label a child that is younger than the age of 18. So I said, well, I think we need to get him in the hospital. He's 4, he's cute, that's what kids do. Later that night, he stabs Grandma, right? And Grandma was the one who was really in opposition to me hospitalizing him. So he stabs Grandma, and he didn't just stab Grandma. He liked to watch a lot of shows, so what he did was stab and turn, because he had realized that if you turn the knife, when you stab, you open the wound and don't allow it to kind of heal or sometimes close together so it stops bleeding. But that child had symptoms really early. He wasn't even in kindergarten. So there are a lot of issues that we see in childhood. There are conducts, there's autism spectrum, and different things that we label them with that are merely placeholders. If you see children with mood disorder, NOS. NOS is none other specified. It just means when you're 18, I'm going to hit you with bipolar. That's all that means. And some parents, when they see that, they think it's a clear departure from the former diagnosis. No, it's not. It's mood disorder, NOS. Bipolar is about moods, right? This was coming. We just couldn't give you that at the age of 18. But now that you have it, it's coming. So even with depression, there's a lot of children that exhibit this, and we consider them to be introverted because we don't understand and aren't equipped to recognize when, hey, this is not within their realm of normalcy. There are some children that are introverted, can play by themselves, but if they're not doing that and they kind of isolate it, there's something more to it. That's why we have to be kind of cognizant. Children are different, but you know your child. If it's outside of their area of normal, then it's cause for concern. Depressed children also disassociate, but now everyone's learning about disassociating and dissociative disorder. Oh, I'm disassociating. I disassociate myself from her. And I'm like, you know that's not a physical thing, right? I'm just saying. That's a mental thing. So you hear that often, but I don't know if anybody has ever had on their report card or seen somebody that kept getting tends to daydream. That means at that moment, there was something so profoundly distressing that the mind takes a journey. And typically, in the beginning, it's done voluntarily until it becomes a coping style and becomes involuntary. Like, oh, I don't want to leave, I don't want to, you're gone. And then we try to piece together what happened before we left and what happened when we came back. That's why people will bring up something that was old and like, hey, we just talked about that. Why are you bringing that back up? Because they weren't present during the time when you teased out that conversation. So children, we need to kind of pay attention. If you know your child, and I'm hoping that everybody does, you'll know what's in the realm of their normal and what's not. And it's okay to kind of bring that to a pediatrician's attention, not that they can diagnose, what they tend to do, give everybody the same drug. Ask for a recommendation to a child psychologist. Because pediatricians will write drugs for things that they have not even really been aware of. They'll prescribe an antiquated drug or a drug with horrific side effects, thinking it's going to perform the same way in an adult as it does a child. So ask for that, and you can kind of go from there.
Can you talk a little bit about some, resources that might be available to help folks who are dealing with these issues, and particularly, depending on the severity, obviously, how much help they need, but depending, especially folks that may not have the financial means to, that some folks are privileged.
There are a lot. The goal is, if you're struggling with a specific area, make sure you vet whoever you are interested in, or it's good to come up with 3 or 4. Vet them. What some therapists and psychologists do is put down things that are popular. However, they have never studied or treated. So it's important that you do that, because you don't want yourself, your child, whoever, to be their test subject. But you want a background history on them, whether they've treated this disorder, whether they've worked with this population before. Also, what you want to do also is be very specific. Some people will come to you, I'm just feeling really sad and really down. And they're very blanketed. You don't want to be titrated and tried on a bunch of medication until we figure out what it is. You want to be very specific about what you're feeling, because the closer you can get to what you're feeling, the best likelihood is you'll be diagnosed with a proper issue and treated in the right way, because some issues can trigger other issues. Say, for instance, if you come in and you're bipolar. I know from my own practice that when people come in with bipolar issues, they come in when they're depressed. Nobody comes in when they're creative, painting their ceilings or making like 30 tuna fish sandwiches for their kid so they can get a head start. Nobody comes in then. They always come in when they're profoundly depressed. So they'll ask me after the first session, hey doc, am I struggling with depression? I don't know, because that's what they want to hear, because it's scary for some people to know that they have bipolar disorder. So I'll say, no, I don't know. We got to wait. You don't know, because I want to see who shows up next week. And the person that shows up next week, if they're bipolar, are usually antsy and more aggressive, because I haven't formed a diagnosis. So I'm like, oh, you showed up. Great. Okay. This is what's going on. Because the person that reaches out is usually the depressed person. The person that comes back, if they're still depressed, oh, okay. But if there's someone else, you got a better idea of what's happening. So look into therapy services, specifically to what you're feeling, and go on reputable sites. I've never seen hard diagnosis treated with a telephone, because there's a lot of telemed, and there's people texting, great job, keep doing what you're doing. And it's like, well, I'm really depressed, keep going, keep going. You really want to know that this person is reputable. So go on Psychology Today, ZocDoc, WebMD, some places where you know that you can't even get up there unless they verified you. You have to send in your license, they have to do your background check, and see if you have any hits against your license. You can tell that too, if someone has hits, and you can actually see what the hits were for. So if you're looking, look on reputable sites. And it's okay to have a consultation. If someone tells you, oh, I don't do consultations, well, I'm not going to do this session. Because they usually get you to sign a contract, like, okay, at least 6 to 8 or 12 sessions. You want to have a consultation to see if you can talk to that person, to see if they're comfortable, you know? Because if they're not comfortable, you're going to hold back. Do whatever you need to do to try and feel better. Don't make any decision rushed because that person tells you, I have a waiting list, you got to come on. Don't ever do that. That means I don't have a waiting list, I'm really hard up for patients, and I really need your money. That's what that really means.
there financial resources that can help folks to get the treatment that they need that you're aware of? Or,
Yes,
where
there
would
are.
you begin to search for
There is, I got a request from some sister project. I can email you that, but they pay for some of the sessions for the clients that are having issues that really need therapy. And sometimes they pay from 6 to 12 sessions, I believe. And if a therapist, it's at a reduced rate, the therapist also has to accept it. If the therapist doesn't accept it, then you have some charges now, like 200, whatever. So what you want to do is see if they accept that. And there are certain therapists, psychologists, that if they want to work with you, they'll work with you on a sliding fee. The only issue is when you have people and you're willing to do a sliding scale. Done that quite a few times, and then people stop showing up. Because what we're looking at is not the money that you're paying. We're looking at the time slot in which you occupy. That would normally be this amount. But because I've reduced it for you, and you're not even showing up, that could have been allocated to someone else.
What is your particular theoretical orientation?
I'm an eclectic cognitive behavioral therapist. What that means is I don't subscribe to just CBT. You hear clients now, oh, CBT, everybody says CBT. And I remember one woman saying, oh, I want a CBT, and that's not what I'm getting. CBT, cognition that changes and affects behavior. Just because I didn't say, hey, we're doing CBT today, she didn't realize that we were doing this, right? Did she try to commit suicide anymore? No. So which means it's working. If you didn't think about taking your life, isn't that not a change in cognition that affected your behavior, that prevented you from acting out? And I believe in narrative therapy, rewriting your life story. We all think that because we fall down, that our life story is meant to kind of play out that way. We can intervene at any time and redact, rewrite through a line through, and change the way our story moves forward. GBT. How you speak to self and how you process your own thoughts and how you interpret what is happening to you. There's also solution focused, like, okay, let's devise a solution. There's strategic, where it can be a little tricky. I'm challenging you to identify resources that you didn't know you had. There's also art therapy. I utilize art for you to communicate through art what's truly going on. Then I use what's called the miracle question. It's a trick question. I'm not going to tell you what that question is. Because then you probably try to use it back on me. But it's a trick question for you to tell me what's really going wrong. But you don't know that you're doing that. There's a number of different ways. Each thing is tailored to the individual. Like, I will never devise the same plan for everyone because that doesn't make sense. You all have different backgrounds. You all have different life experiences, different relationships. It'll be tailored to who you are and what you came in for and what resolution you're seeking to obtain. So it depends on who you go to. There's CBT, there's narrative, I'm eclectic. It depends.
We could probably go on for hours because just a font of information and wonderfulness. We can't thank you enough for being here. One of the things that we do here, again, at Justice, is we try to deepen the conversation of the themes that our shows bring up. And I learned so much here just sitting here today. And I thank you so much. And thank you for being a part of what we do. And thank you for all you do for the folks who really need you.
Thank you.
Folks, the show will begin